Just kidding. Okay, so we are going to continue on with our talks of endocrinology, and the first stop on our endo train is going to be the Mellitus. Yep. Listen, this man taught me more about medical supplies for diabetes than any other, so learned a lot from Wilford Brimley. Anywho, all right, so we know that glucose is very important for energy production within the body. You know, the brain is especially dependent on having glucose in order to produce energy. A lot of other energy stores that we'll talk about as well. But we know it's helpful for making things like, you know, our amino acids, our synthesis of lipids, nucleic acids, all kinds of good stuff. And so, you know, there's like a minimum requirement that the body needs like per day. This is usually kind of like what your brain needs, especially to just operate. And you're going to see that if you have dysregulation of that, lots of other problems can pop up. And you guys have talked about this at all in CMS yet? Oh, it comes after spring break, so you guys get a sneak peek. You guys know how to treat it before you know what it is, right? Just kidding. Okay, but we also know diabetes can be related back to this metabolic syndrome that is characterized by having an elevated glucose, along with things like cardiovascular disease risk. You're going to see that diabetes can influence a lot of things like having neuropathies, nephropathies, and retinopathies, right? So you think about that kind of older diabetic patient who is overweight, has at least one foot amputated, and is not really able to see much at all, right? You think of that kind of patient, those kind of very poorly controlled diabetics who unfortunately are, you know, get very, very progressive in their disease and don't really take care of themselves. But hopefully nowadays with a lot better medications and things like insulin, hopefully we can keep them from getting to that spot. So as far as diagnosis goes, I won't get super in-depth into that, but you guys know kind of the classic triad of symptoms for diagnosing diabetes being polydipsia, polyuria, polyphagia, right? So those are like kind of the big three things that you look for, and you kind of thinking of diabetes when you kind of hear that. But also the kind of the most definitive thing we're going to be looking at is their glucose, right? So looking at things like random glucose is greater than say 200 milligrams per deciliter, or if they have a fasting greater than 126. You may see the definitions change a little bit based on which organization you're looking at, but these are kind of general rules that you can kind of follow for this. You can also do glucose tolerance test. Do you know what type of patients we most often do that in? Yeah, pregnant patients, right? So we'll do check for gestational diabetes and those type patients. And also looking at the glycosylated hemoglobin, your A1C. So what does A1C tell us? Yep, so your average of how much glucose your hemoglobin is carrying around for the past, what time frame? Why 3 months? That is the life cycle of the red blood cell. Absolutely, right. So it basically gives you an average for kind of what the hemoglobin has been carrying around. And so if you have like 1 point rise in your A1C, what does that kind of correlate to in rising glucose? Does anyone know that? It's around like 27-ish milligrams per deciliter, so you can kind of gauge, you know, so if you have a patient who's at, say, A1C of 7 and they go down to an A1C of 6, you can kind of say, like, okay, well, they've had at least, you know, an average of a drop of 27 milligrams per deciliter in their average glucose reading. So, and it's just kind of a handy number to keep in mind. So we know that we have a couple of varieties of diabetes. So type 1 being those patients who require exogenous insulin for survival. So again, we'll look at their pathophysiology in just a minute, but basically they're not able to produce their own insulin. You may have some patients who have this kind of type 1.5 diabetes where you have this kind of latent autoimmune issue that pops up where they have kind of late stage destruction of those beta cells that happens there. And then the majority of patients are going to have your type 2 diabetics you're dealing with. A decent number of them are going to go on to require insulin at some point, but you may have a larger proportion that never require insulin therapy. But we'll look at kind of when is a good point to kind of initiate that based on you know how they're responding to therapy. Gestational diabetes, you know, is a small portion of those pregnancies, and then you also kind of like the pre-diabetic stage, just like you have things like pre-hypertension. You have this impaired fasting glucose. And we'll talk a lot about this because a lot of the pathophysiology for the type 2 diabetics is the fact they're so resistant to insulin, right? Because we mentioned that when you have a lot of, you know, a ligand binding to a receptor, what do the receptors do over time? They upregulate or they downregulate. They downregulate over time, right? You become more resistant to that influence. And so the same thing happens with insulin. If you're constantly kicking out tons of insulin from the pancreas, you're eventually going to have downregulation of those receptors and your tissues get more desensitized to it. So this is going to be one of the big problems you see with a lot of type 2 diabetics. Sometimes, rarely with some type 1 diabetics are poorly controlled, but this is a big component to it. And so we're going to look at some drugs that work specifically to increase insulin levels, which is great, but there's going to be a number of other drugs that work specifically to sensitize the body to insulin, make it work a little bit better. And so those are going to be also very useful drugs because we'll look at some of the characteristics and why that is in just a little bit later. So, most frequently, if you're looking at morbidity and mortality of these patients, usually type 1, you can see renal disease kind of being a big problem for them. Again, if you just imagine just this high amount of glucose just constantly being filtered through the glomerulus, kind of just shredding it eventually to make it less effective over time. But the type 2 diabetics, typically macrovascular disease is going to be the thing that gets them, right? Typically, they already have kind of pre-existing cardiovascular disease to begin with. This is just kind of accelerating that process, right? Because having high amounts of glucose puts you in kind of a more kind of pro-inflammatory state. You see further progression of those atherosclerotic plaques and development of that. So that's why they end up, eventually succumbing usually to like a heart attack or something like that. But as far as risk factors go with type 1, usually it's going to be genetic in nature, but you could have other things like viruses playing a role here. But type 2 diabetics, looking at family history can kind of let you know what the risk is. Like I have a long line of diabetics in my family history, so I know that's something that I need to be worried about. But ethnicity, obesity, lifestyle can all play a big role here, right? So looking at the pancreas and the things that we're going to be secreting, a lot of these are going to be important when we're talking about the medications that we're looking at and the ways that we're going to be able to kind of influence these hormones to treat our diabetic patients. So one of the first big ones we'll talk about are going to be these alpha cells. It's about 20% of the cells in the pancreas. These are going to be really important for mobilizing glucose, right? So the big hormone here that we see is going to be glucagon. Glucagon normally is going to be stimulating glycogenolysis and gluconeogenesis within the liver, helps to liberate those, break down glycogen, which is just stored up carbohydrates, and release that into the bloodstream, right? If you had to think, does your sympathetic or parasympathetic nervous system really kick off glucagon, increase secretion of it? Should be your sympathetic, right? So if you imagine if a bear pops out and you need to run away from it, you need glucose, right? You need energy to do that. So you'll see that patients are in a more of a kind of a proadrenergic state. You're going to find they have higher glucose secretion. So that can actually be kind of a component of things you can look at when you're kind of evaluating your patients. So kind of keep that in mind. If you're looking at your beta cells, this is going to be the higher proportion of cells here. These are going to be promoting more fuel storage and helps to promote growth. This is where you're going to get a lot of things like insulin, which we will be talking about extensively here. But you also have things like amylin, which is being released as well. And so you have drugs that are going to be helping to kind of either help things like amylin work better, or you're going to have some drugs that actually help to mimic the effects of amylin, because this will have a big effects on things like satiety, on gastric emptying time, and it'll help the patients to feel fuller, faster, and you'll actually see some of these drugs actually have a good effect on weight gain in addition to depressing levels of glucagon and helping your insulin to work better. And then you have a couple other types of secretory cells. We won't really talk too much about those. But somatostatin, you guys know, another drug that is an analog of this, I guess is an analog of it, but a drug that we give that works just like somatostatin. No, it's misleading because it has statin in the name, but yeah, so octreotide. So octreotide, we give that occasionally, and that is actually just a synthetic form of somatostatin. Do you guys know where we give octreotide? Yep, so if esophageal varices is one case.
Sometimes the ulcers?
Potentially, yeah, sometimes you might see that. I use it most frequently for if I have a sulfonylurea overdose. This is one of the drugs that we'll look at for treating type 2 diabetes, but we can actually use octreotide to block insulin secretion from the pancreas, and so that actually helps to correct the glucose a little bit faster for those patients. So you'll find a couple of different reasons for octreotide use. You most frequently probably see it like in the emergency department for like a variceal bleed or something. That along with like a proton pump inhibitor drip or something, you can see it used pretty frequently. Anywho, all right, so we'll talk all about these more in detail as we go along, talk about the medications that affect them. So you can see here how things kind of change over time, going between someone who has a normally functioning pancreas over to someone who has like type 2 diabetes. You're going to be seeing that over time, you're going to have dysfunction and dysregulation of hormone secretion from the pancreas, so that you're going to have increased levels of glucagon, which we know glucagon does what to blood sugar levels? It's going to increase it, right? Because it's going to have, stimulatory effects on the liver to increase glucose production. And you're going to see fewer beta cells. So if you imagine they're just going to wear their pancreas out over a period of time, their beta cells, they worked as hard as they could, but they just, crapped out and they can't really send out any more insulin. That's why you have such dysregulation in their glucose levels. The other important thing to consider is that when you actually diagnose a person with diabetes, similar to what you see with like renal disease, is that by the time you get to a point where you have a diagnosis, you've already had significant destruction of the natural ability for you to kind of regulate things. So by the time you get down to a diagnosis of type 2 diabetes, you've probably lost about 50% of your pancreatic function at that point already, right? So you really want to catch these patients earlier. The earlier the better, especially if you can catch them during that kind of impaired glucose tolerance phase, right? That's going to be when you have the most chance of having the biggest impact on preserving further pancreatic function. So on the other hand, with your type 1 diabetics, they're going to have this extensive kind of loss of their beta cells. Usually it can be related to an autoimmune disease where basically their own inflammatory system cannot differentiate itself from foreign proteins, so it actually goes after those islet cells, and so you can actually detect those antibodies and whatnot. You may have some non-immune or idiopathic type 1, but it's usually going to be in the minority of cases for those patients. So insulin is going to be our probably the biggest hormone we're going to talk about here, glucagon probably being a secondary one. When you think about insulin, a lot of people don't think of it this way, and I didn't for a while either, but think about it like an anabolic steroid, okay? So when I say anabolic steroid, what do you guys think of? Think about weightlifters, you think about what other type of hormone? Testosterone, right? So you think about testosterone being anabolic, means it's going to be building up tissue, it's going to help to increase muscle growth. Insulin does the same thing, and so you can actually find some cases where bodybuilders who are trying to put on muscle mass, they'll actually use insulin after a workout, after they've had like an ingestion of carbohydrates and protein and whatnot, because of the actions of insulin, because of it has this pro-growth effects on it, right? So think about like an anabolic steroid, and that helps you kind of to categorize how it's working within the body. We'll kind of categorize that a little bit further as we go along. But insulin itself, does it get released as the active form when it comes out of the beta cells? Yeah, I'm asking the question. Probably no. It actually comes out as proinsulin, right? So proinsulin gets released from these beta cells, and then it gets cleaved into two proteins, right? So it gets cleaved into the insulin component, which is the thing we want, and it also has a C-peptide level. So you're going to find that for every molecule of insulin, you should have a molecule of C-peptide being released as well, and you can actually measure that, and that can be important in some cases. I always link it back to this kind of probably a rare thing you're never going to need to use it for, but you can use it for actually forensics potentially. So imagine, if you're injecting exogenous insulin, or if I were to, give you a dose of insulin, subcutaneously, you're not injecting any of that C-peptide. You're just injecting the insulin. So for instance, if a wife wanted to murder her husband, as my wife sometimes may want to, and she were to inject me with a whole ton of insulin, do you think my C-peptide levels would be high, low, or normal? Should be low, right? Because I have a lot of insulin in my body, and that would tell my pancreas, hey, you don't need any more insulin. So C-peptide levels would be low. Versus if you were to measure if it was a person who, say, like had a sulfonylurea, which stimulates insulin secretion from the pancreas, or they have like an insulinoma or some other reason why they have hyper secretion of insulin, their C-peptide levels would be elevated, right? So that can actually help guide you to see whether or not it was exogenous versus endogenous insulin being released there. But so just think about C-peptide as another kind of index of insulin secretion. If that's elevated, that gives you a sign that your patient is probably releasing a lot more insulin than what they may need. But you'll also find that degradation of that bond between the C-peptide and insulin comes from this insulinase, and then once insulin is released, it is able to stick around for a short period of time, usually about 3 to 9 minutes. So it's a very short-acting hormone, which is why your pancreas isn't needed to kind of continuously send it out. Important to know how it gets cleared though. 60% about in the liver, 40% of it in the kidney, and this is really important if you ever work in say an ICU. A lot of times in the ICUs, you worry about having those patients have too high glucose concentrations. If you imagine having too much glucose around, you have kind of a pro-inflammatory state. It gives more fuel for the bacteria to grow on. Like, you really want to have a little bit tighter control of their glucose than what they may have naturally. So a lot of those patients get put on insulin drips, right? Which continues infusion of regular insulin usually. But one of the things you find is that especially in those sick ICU patients like sepsis or hyperperfusion of the kidneys, they have a decrease in their kidney function, acute kidney injury. That can actually lead insulin to have a longer half-life, and so you may have issues to where you can't figure out why they're getting hypoglycemic based on the insulin that they're receiving, but a lot of it could be related back to their decrease in kidney function. So always think about that. If they have poor kidney function, insulin sticks around for longer, bigger risk for hypoglycemia. Okay. So how does insulin get released from the pancreas? Well, basically when it gets exposed to higher levels of glucose, and I'll show you a picture here in just a second that'll kind of illustrate this. As you have increased blood levels of glucose, that gets bound to this GLUT2 transporter. And I'm not going to get super in depth. I'm going to talk about a couple of different GLUT transporters here, but I'm not going to ask you specifically which GLUT transporter. That's more like a physiology class kind of question. But basically, it binds to the GLUT2 transporter. The glucose gets taken into the pancreas where it gets metabolized and turned into ATP. Right? ATP stands for. Yeah, good. Adenosine triphosphate. That's where we get all of our energy from, right? So it goes through that TCA cycle, produces ATP, and it's a high energy molecule. That ATP is then going to close these potassium efflux channels. So normally the beta cells would be sending potassium out of the cell in order to maintain a normal resting membrane potential. ATP helps close that. So you have higher levels of potassium within the cell. That's going to trigger off an action potential, which is then going to open up calcium channels. Calcium is then able to flow into the beta cell, and that actually causes release of these vesicles that contain insulin, or actually they contain the proinsulin, which then gets cleaved over into insulin and C-peptide. Okay, so this process is important because we'll look at a few different drugs that can influence that, including things like our sulfonylureas, things like octreotide can all have effects on this process. So if you can imagine here, I'll get my laser pointer. So you can see glucose coming in through this GLUT2 transporter, gets metabolized to ATP. This will then close these potassium channels, which normally potassium is getting sent out of here. This will close it off, right? So your internal electric potential starts to increase. It will trigger depolarization of the membrane, and then this is going to open up these calcium channels. Calcium flows in, and calcium is going to cause exocytosis of these insulin kind of vesicles, right? And then you have insulin in the bloodstream that can do its thing. Okay, this is important because when we look at drugs like our sulfonylureas, they actually work specifically to close this potassium channel. So if you can kind of artificially close that potassium channel and cause that membrane, the action potential to occur, you can have more insulin release, right? You'll see things like octreotide can work specifically here at the calcium channel to block that. So octreotide can lead to hyperglycemia potentially. So that's where we use it for sulfonylurea overdoses. We actually use the octreotide to directly block that calcium channel to prevent the sulfonylurea effects on the potassium channels from releasing more insulin. So kind of see how this how they kind of work hand in hand. So then once the insulin is released into the bloodstream, one of the more important glucose transporters is going to be this GLUT4, and so this is going to be important for the peripheral, especially the muscle tissue. Once insulin initiates this phosphorylation cascade and interacts with these insulin receptors, it's going to actually translocate glucose transporters out into the actual cell membrane. Okay, so insulin will bind, cause a cascade of events, and cause the glucose transporters to be put onto the actual cell membrane to allow glucose to come in. It also includes other things like amino acids and lipids and other things like that to come into the cells themselves. Okay, then glucose can obviously be either used directly for energy, or it can be stored up as what? Glycogen. And then what does glycogen eventually get turned into if you have too much of it? To the fat, right? So you get turned into adipose tissue eventually. So again, this is just kind of a little bit more complicated version than we probably need for our purposes, but you'll see here how insulin is going to bind to its receptors, and it causes, you guys remember those tyrosine kinase receptors we talked about back in pharmacodynamics? Rears its ugly head every once in a while, right? Anyway, once you this binds here and you end up phosphorylating this receptor, it's going to cause all these different changes in gene transcription and things like that. But eventually, these GLUT4 transporters get translocated out here to the actual cell membrane, and that's where glucose can come in. That's where other things will also be coming in as well, like amino acids and whatnot. Okay, so if you can imagine, if you have patients who are chronically having high blood glucose levels, causing their pancreas to constantly be sending out a lot of insulin, these receptors are going to start to downregulate, or they'll get desensitized to the point where they're not going to work as well. And then if you imagine less glucose transporters making out to this to the cell membrane, thus less glucose getting into the cells, thus higher blood glucose, right? So all these things are going to be kind of working against the type 2 diabetic, and so if we can reinitiate or resensitize any of their tissues to this, it's going to be a good thing. It's going to help to regulate their glucose even better. So again, there's a couple of different types of glucose transporters. You'll see, some are specifically in the muscle and the adipose tissue. So GLUT4 is really important here. Again, GLUT2 is important for the pancreas. You'll see other ones specifically for the gut, specifically for the brain, things like that. But just realize there's different types of transporters. They'll have kind of their place within the body. So, looking at the physiologic effects of insulin, and again, think about it as an anabolic, hormone. Looking at their effects in the liver, when it gets stimulated by insulin, you're going to be seeing storage of glucose as glycogen, which is kind of our fast-acting energy stores. You'll also have some of that being converted over things like fatty acids, VLDL, and then eventually adipose cells, right, or adipose tissue. It'll also inhibit glycogenolysis, gluconeogenesis, and that conversion of fatty acids to ketones, right? That's going to be important because, again, when you have an absolute deficiency of insulin, what happens to those patients? They try to burn fat, and then that produces ketones, right? So they go into that diabetic ketoacidosis, right? Because they basically they don't have the insulin around to actually stimulate this process, and so their cells and their tissues can't utilize glucose appropriately because it's not really being transported into the cells, right? That's our fast-acting energy stores, and so if it doesn't have that, we're going to rely back on using things like oxidizing fatty acids and things like that, which produces acids, and this is why you see those patients get so acidotic, right? But again, those patients have a absolute deficiency of insulin, so that's why we give them more insulin, and that helps to correct the problem. Over on the skeletal tissue side, when insulin interacts with these cells, you're going to see storage as glycogen. You'll also have the storage of the amino acids that gets converted into new proteins. That's where you can kind of see those anabolic effects there. Also helps to inhibit protein degradation converted back to amino acids, right? Because again, if you don't have enough amino acids, your body will start to break down protein tissue eventually in order to get that. So insulin is inhibiting that process. And then eventually for the adipose tissue, insulin will also help to promote storage of fatty acids as triglycerides, and then what also will inhibit that process, the reverse process there. Okay, so lots of things that insulin is doing to help kind of store up more energy in order to have better stores that can be used later when insulin levels are low or when your glucose is low. Okay, so looking at insulin release, it's important to look at this when we are considering how we're going to be dosing insulin for our patients, because we know that the pancreas is always working, right? It's always kind of sensing the glucose levels within the body, and it's responding to it appropriately. So if you're looking here at our glucose levels, and then also looking at our insulin levels as well, you can see that the pancreas responds pretty well to this. And so you should have some kind of basal level of glucose around, right? Because you always need some glucose in the bloodstream. Because if it was 0, you'd be probably seizing or dead or something. So you don't want that. So you at least want some kind of baseline level of glucose in the body. You're also going to have a basal amount of insulin being released as well. And so this will come into play as well when we talk about things like subcutaneous continuous infusion insulin pumps. We'll talk about that in detail a little bit later. But basically, you're going to have a basal amount of insulin being released, and that gets stimulated when you have increases in glucose, which most often occurs around meal times. Absolutely. So when you have breakfast and you have a big spike in your glucose, which you can see here, your pancreas responds by having a big spike in insulin, right? Similarly around lunchtime and supper time and all of that. So what you see with a lot of our insulin regimens is that we are trying to mimic this as best we can. Okay, we'll talk about some of the kind of the pros and cons of either going with more frequent administration versus less frequent, but this is essentially what we're trying to do. We're trying to mimic the effects of the pancreas and how it responds to glucose as best we can. So looking at different insulin formulations, there's lots of them out there. Okay, so it's important to be able to look at an insulin and know what kind of release characteristics it has and know how long the effects are going to be. Because if you give the wrong type of insulin to a patient, that can be very problematic, right? These are drugs you do not want to goof up because lots of people have died from having insulin issues, either the wrong formulation given, the wrong dose being given, wrong concentration. Very, very dangerous drug if you goof this up. So be very careful whenever you're dealing with insulin for these patients. But looking at the different formulations, you're going to have different times in their onset of activity. So we're going to talk about ones that are very short acting. We'll talk about ones that are very long acting and how fast that they're going to actually have effects on the glucose. And then also duration of action is going to be really important. The solubility characteristics is going to be important for the long acting formulations because how do we normally give insulin? By injection. So what type of injection? Usually sub-Q, right? Why can't we give it orally? Yeah, it's a protein, so it gets degraded by the stomach acid, right? So we can't do that. Do you guys know any other routes we can give insulin? We would not give it rectally, no. Almost intranasally. You can actually do inhaled insulin. So there will be there's a formulation of inhaled insulin we'll talk about a little bit. You can also give it IV as well. So that's especially in your DKA patients, we'll look at how you can give the IV. But sub-Q is going to be the lion's share of people getting it via that route. But anyway, when you inject some of these long-acting formulations, because we mentioned the half-life of insulin is very short, a lot of these formulations are given so that they stay out of solution for as long as possible, and they kind of get slowly brought in and slowly dissolved and leaked into the bloodstream. And so you'll see some more long-acting forms get longer durations of action because of that. I'm not going to get super into detail on those, but be able to recognize whether it's a long-acting insulin, short-acting, intermediate, be able to kind of characterize all those different insulin formulations. And we'll look at those in just a second. Other things you can do to vary the pharmacokinetics is if you can put zinc into it. So if you ever see a lente form of insulin, which doesn't get used too frequently, that has zinc added to it in order to help change its release characteristics. Adding protamine to it will get you your MPH formulations, which again I don't see too often, but every once in a while you might see it being used. And then also looking at insulin analogs, by switching out certain amino acids, you can actually change the characteristics as well. So we'll look at that in just a second. So here you can see our insulin molecule. If you guys can just memorize the whole structure here, so if you can just name out the amino acids in order, that would be great. Just kidding, I'm not going to have you do that. But you can see where and even looking between different mammal species, you can see some homology here between insulin and of human derivation and also that of, like, say, bovine insulin, right? So cow's insulin is actually very similar to ours. It just has a little bit different amino acid structure here, just one, right? One change there. But you can see other types of formulations where we will change some of the amino acids and get very different characteristics. So things like Lispro, where we actually change out a lysine to proline. Here, this 28 and 29 space protein, that will give you a very fast-acting insulin, right? Aspart is kind of the same thing. So you have very fast-acting insulins just by changing one or two amino acids, right? So it's kind of interesting just how small changes like that can change the characteristics of the insulin entirely. But so looking at where we normally get our insulin from, back in the day, back before we had recombinant ways in order to make human insulin, we actually used to use animal-derived insulin. So beef was a big source for it. Pork was another one. We don't usually use beef anymore because it is highly antigenic. Again, anytime you're injecting foreign proteins, you run the risk of having an allergy to it. So even the few amino acid changes may be enough to set some people off, right? So don't use bovine anymore. Pork may be used by special order only if it's like a patient who really can't tolerate any other types of insulin. I've never seen a patient like that, but you may see it every once in a while. Most of the insulin we have nowadays is going to be human recombinant, but it's made either from E. coli or it's made from yeast. And so basically, one manufacturer has like their form that they use with the E. coli, and then the other manufacturer uses the yeast. So not a huge difference in the actual insulin that's produced. It just depends on what brand you have and what kind of formula, what's on the institution formulary. So for instance, the Lilly products is Humulin. So you'll see like the Humulin, Humulog, other things like that fall under that category. That's all made from E. coli. And then also the Novolin is going to be from Novo Nordisk. That's going to be from baker's yeast. Not super important for your guys' purposes. Just realize that's kind of the difference between them because therapeutically they're almost used interchangeably. It just depends on what your patient was on previously and then what your formulation, what is on your formulary. So. I'll show you another table that has kind of the full list of different types of insulins, but basically the way they can be broken down is their duration of action and time of onset. So you have ultra short acting insulins. When do you think it's going to be best to give these types of insulins? Yeah, mealtime is going to be one of the best times in order to utilize these. Short-acting insulins, like regular insulin, this is basically just the human form, right? That'll be also used for things like meal times. You'll use these a lot for corrections of blood glucose. We'll talk about different ways to correct that. And then you have some of your more intermediate acting. So you have like your NPHs, you have your ultra lentes, which will be long-acting. The most common ones that I see being used nowadays are going to be your ultra long-acting insulin. So things like your glargine, your Detamir, and I'll have the brand names up on the on the table in just a few minutes. And also one of the newer ones, actually, this insulin degludec. It's actually the newest one, has the longest duration of action, something like 36 hours sticks around for. So you can see just by changing the formulation, you get much longer duration of actions. And then there's also the inhaled form, which is called Afrezza. That they used to have another one back when I was in school, probably like in the 2006 to 10 period, called Exubera, which actually got taken off the market because no one liked it. So we'll see if this one actually sticks around at all, but who knows. So you can look at the characteristics here of how these different insulins have their activity. This is important to note, especially because you don't want to give things like long-acting insulins when you meant to give a short-acting, because they'll have totally different characteristics. So for instance, here you have things like your insulin lispro, your aspart, and your glulisine, which are your ultra-short-acting. They're going to have a very high peak of activity very shortly after being given the subcutaneous injection, right? It'll be absorbed very quickly from the subcutaneous space, gets into the bloodstream, and has its effects on the glucose very quickly, right? So this is why you give it around meal times in order to help correct that big influx of glucose the patient has after they eat. Okay, regular is going to look similar. You won't have as high of a peak. It won't act quite as quickly. So this one you may need to give a little bit before you eat. You know, so really glulisine is the only one you can really take with like the first bite of food. Usually the ultra short actings you want to take a little bit before meal time in order to help give the subcutaneous space time to absorb it. But then looking at your longer acting formulations, you see here how they have smaller and smaller peaks to a point where things like glargine almost has no peak effect whatsoever. You just have this kind of nice, long, consistent effect on the blood glucose. And so that very much mimics your basal amount of insulin the pancreas would be releasing anyway, right? So very frequently, you're only going to give something like an insulin glargine like one time a day because you're going to have pretty much 24-hour coverage. There may be some cases where we give it twice a day for really uncontrolled type 2 diabetics, but for the most part, once a day dosing is used for a lot of these ultra long acting formulations. So you can either give those at like in the morning time, along with your insulin dose for breakfast, or sometimes people get it at nighttime. Just depends on what their regimen is. So we already mentioned that we very frequently give this by injection, usually in the subcutaneous space, but you can also give it IV as well. You will also see other dosage forms being used. So very frequently, all we had were vials that basically the patients would draw out, their doses out of, which we still use very frequently. But you can also have the portable pen injections, and basically, you guys have ever seen a pen product? You can Google pictures of it, but essentially it has a cartridge in the pen that has the insulin contained in it, and you basically can dial in your dose. There's a little dial at the top where you kind of change it to whichever dose you want, put a pen needle on it, and then you just inject yourself subcutaneously, right? Do you see any problems with utilizing the pen product?
Spring breaks, and then you have to use, to try to fill it out again.
Oh, that's a bummer. It's nice to have personal experience here. So that could be, so you have device malfunction, that could be problematic. If you have someone who had very poor eyesight, especially like a type 2 diabetic who's had retinopathy, you may not be able to see what dose they're actually dialing, and they can have problems injecting that. But on the other hand, in order to drop doses of insulin, you have to be pretty dexterous, right? You have to be able to manipulate the vial and the syringe. Easy enough for younger patients to learn, maybe more difficult for older patients, especially imagine those kind of ones with like rheumatoid arthritis. Like they're not going to have an easy time to be able to manipulate that kind of stuff. So a couple different varieties there. You can see in this middle picture here, this is the first subcutaneous insulin pump ever made. Can you imagine carrying that sucker around all the time? Yeah, looks like a little proton pack there. So that was the kind of the first one. We've gotten a little bit better since then. So this is kind of a modern looking subcutaneous insulin pump nowadays. So these pumps, what type of insulin do you think you'd put into that type of pump? Yeah, only short acting, right? So you'd only really be putting in usually like insulin aspart or insulin lispro. So usually like your Novolog or Humalog, those are the brand names there, which I'll show you in a minute. But those would be the ones that go in there. And so basically, those are providing kind of continuous basal amount of insulin being infused 24 hours a day. And then the patient will actually program in their bolus doses in order to account for their mealtime insulin. So they'll basically put in their blood glucose, and depending on how fancy of a pump you have, some of it will be able to calculate the insulin dose to give based on the amount of glucose you put in and your carb sensitivity ratio and all kinds of different stuff. But basically, this is what they end up looking like.
What kinds of patients require the pump? Is it just a personal preference? Or?
That's a really good question. So basically, you want to have patients who are very well controlled on subcutaneous regimens, right? Because you can really screw this up, right? Like I've had patients who had pump malfunctions, either come in very hyperglycemic or hypoglycemic, but you need to be very savvy with how you manage your glucose, because you always have something infusing, right? So if you goof that up, they can get hypoglycemic, you can find them in a coma and they're dead, and it's no good, right? So they need to be well controlled on a subcutaneous regimen. They have a good control of diabetes. They are on a good regimen with their carb counting or whatever their regimen is for correcting for food, and then they can actually manipulate that thing. So we have a ton of young children and adolescents who get put on this, and they do extremely well with it, right? So especially young kids, like they learn how to use it. I've seen like 6-year-olds that can use this thing better than I ever could, right? And they know exactly how to calculate how much insulin they need and what their basal is, what their boluses are. So those are good patients for that. Someone who is only getting, say, like, a type 2 diabetic who you're converting over to having a long-acting insulin that they can just inject one time a day, not good for that, right? So usually type 1 diabetics are at least that's all I've seen, are type 1 diabetics being put on this. So good question.
Why do some need to be refrigerated? And so this insulin doesn't need to be refrigerated?
So they all need to be refrigerated, right? So they're all stored refrigerated. I'm actually not sure about the inhaled form. That might have a little bit less problems with it since this is dry powder. But all the liquid formulations, which is everything else, they are stored refrigerated. But once you take it out of there, it's usually good for about 28 days at room temperature. Right. So I'm not sure how often the insulin pumps need to be refilled. It just depends on how much they're getting. Each one will hold a little bit different amount. Do you guys know the concentration that insulin normally comes in? Call it U100, because again, how do we dose insulin? In units, right? It's always going to be in units. It's not U's, it's in units. You want to write that out. So we dose it in units, and usually it comes as a U100, we call it, where it's 100 units per ml of insulin, right? So you're using very small volumes of a drug that you're giving here. Some patients you may see use different concentrations. We'll talk about problems with that. But basically, the stuff is good at room temperature for a period of time, but that's something you have to consider. Like, us being here in Florida, if the patient, left their insulin in the car, with it being 1,000 degrees outside, there might have increased degradation of that. So you're like, well, why is their glucose not being well controlled? And they're like, I'm sticking to my diet, I'm injecting like I'm supposed to, and they're still having no effect. Think about how they're storing their insulin. Yeah. Okay, here's also the inhaled formulation. This is Afrezza, where basically you have insulin cartridges that get injected, or I'm sorry, get put into this kind of inhaler device. When you close it up, it punctures it, and then it would inhale. Those actually come in, I think it's like 4 and 8 unit increments, so you may need to use like kind of multiple ones to inhale this. I've never seen this used in the wild, but could be convenient for some patients. It's not like our patients are animals or anything, but out in the real world, I'll say. But basically, these are going to be for patients who do not want to have as many subcutaneous injections, right? Because obviously having to inject yourself all the time is no fun. So this may be one alternative for those patients. Okay, so here's the list of insulins that you should be familiar with. I will tell you the ones that the most use are going to be your rapid-acting insulins, your short-acting insulins, and your long-acting insulins here on the bottom. Okay. So the insulin Humalog, the Novolog, those are your Lispro and Aspart. Again, just being able to kind of categorize what kind of release characteristics it has is probably the most important thing, right? Because even me, if you put a gun to my head and said Humalog is which type of insulin, I'd be like, it's either Lispro or Aspart. I don't really remember off the top of my head because I don't really need to know that, right? But being able to recognize that, okay, that's a short-acting insulin. I know that it's going to have these kind of characteristics. That's the important thing to know. Apidra is probably the fastest acting one, this insulin glulisine. That one has the ultra short acting. So that one you can actually take with the first bite of food even. It has good effects on your blood glucose. Notice how most of these either come as a pen, usually a 3 ml pen, or it'll come as vials, right? So the patient can draw up their own doses. And then again, the long-acting insulins get used very frequently for usually either one-time daily injections or maybe twice daily in some rare cases. This is where you have your Lantus, your Levemir, and this new one, this Tresiba, which is the insulin Degludec. That one has the longest duration of action, something like 36 hours. So it sticks around for quite a bit. You will also have certain mixtures of insulins that can be given. So you can see here, if you ever see Humalog mix 75-25 or 70-30, those are basically just different mixes of long-acting and short-acting insulin. So for instance, here in this Humalog mix, you can see that it includes the protamine insulin, which we mentioned protamine increases the duration of action of insulin, along with the Lispro, right? And so basically you have a short-acting form that's being used for that around mealtime, and then you have a long-acting form that usually gives you around 12-hour coverage or so. So I see it used less frequently, but every once in a while you may see it being done. So what's the benefit of using a mix of 2 insulins in one product? Yeah, fewer injections is the big thing there. So it's usually the one reason why you would do that is to save yourself some injections. Okay. Also, look at the different forms of concentrated insulin. So you can notice that most often we use U100 insulin, which is 100 units per ml. But in some rare cases where you have very insulin-resistant type 2 diabetics, you may need to use more concentrated forms in order to limit the volume of insulin you actually get, or the volume of fluid you have to give in order to get the insulin dose in. So if you imagine if you goof it up and give someone U500 instead of U100, what do you think their glucose is going to do? It's going to be undetectable probably, right? So you do not want to goof that up. There have been several hospital-related deaths that have occurred by mixing these up. Cases where sometimes, you guys know what TPN is? What does it stand for? Yeah, total parenteral nutrition. Sometimes insulin's added into those bags. If you goof that up and put the wrong insulin into that bag, it can have very deleterious effects on your patient's glucose. So there's been lots of deaths associated with insulin. So be very careful anytime you're messing with different concentrations and just different forms of insulin. So for instance, just to give you an idea of kind of the stops in place to prevent errors like this, like at Nemours, what we do is anytime an insulin dose is drawn up, one, we are doing barcode scanning technology to make sure that our electronic medical record system can detect whether, yes, this is actually Lantus you're scanning, right? So that's one check. The pharmacist checks it off. We have a second pharmacist check it off to make sure it's the correct insulin and the correct dose. Because you imagine the volume you're drawing up is very, very small, right? So if you need to inject, say, 10 units, how much volume is that if you're using a U100? It's like 0.1 mLs, right? So it's very, very small volume, and usually patients get smaller doses even than that. So very small volumes, you need to make sure it's drawn up appropriately. And then the nurses, they do independent checks as well. So one nurse will come in, they'll scan it and say, okay, this looks like the right insulin, or the right dose at least. They'll have the second nurse check it as well, okay? So because it's such a high alert item, such a high risk, we have multiple checks in place to avoid goofing this up, okay? So just be aware of that. And then, again, the inhaled insulin has the best name ever. It's called the Technosphere insulin. I'm not sure who came up with that, but they are a genius. Okay, so looking at the characteristics, don't memorize these numbers specifically, but just be able to kind of generalize about what the different properties of the insulins are. So if you're looking at something like Aspart or Lispro, notice that the onset is around 15 to 30 minutes, right? So you would be having your patient take this maybe 15 to 30 minutes before they eat, right? That way it will be able to be absorbed and be able to kind of counteract the big influx of glucose that you would see with a mealtime, right? Notice that the peak very soon, and they have a very short duration of action. Okay. Whereas if you were to compare it with something like, say, your Detamir or your Glargine, notice that it takes a long time for it to actually have an onset, right? So this is not going to be a rapid-acting process. You normally would, say, do an injection in the morning of your long-acting formulation, and it gives you nice long coverage. You can see here anywhere between 14 and 24. To see that Degludec is around 36 hours or so. So good long-acting drugs, usually one-time daily injections. Okay, so you just be able to kind of generalize about the different characteristics there. Notice that the long-acting forms do not really have a peak effect, really. They're going to have kind of just a nice mimicking of that basal insulin that your pancreas would normally be releasing anyway. Okay. The only reason why the appearance is here, clear versus cloudy, that is more important for patients who are injecting multiple types of insulin at the same time. As a general rule of thumb, never mix your long-acting forms with anything else. So like your Glargines, your Levemirs, your Degludecs, like don't mix those with anything else, okay? But in some cases, like we mentioned with those mixes before, some patients will mix a short-acting one with like a protamine insulin, right? And so you always want to make sure you do you drop your clear before you're cloudy. I'm not going to ask you guys to remember that because it's not something we do very frequently anymore. You guys can learn that in the real world. Okay, so complications of too much insulin. Obviously hypoglycemia. As I already mentioned, the kind of inherent risk for using different concentrations of insulin, so I won't kind of beat that dead horse. But other problems you can actually run into somewhat infrequently, but you may be worried about. So some patients may have a true insulin allergy. This is not super common, especially because a lot of the products we're using are so close to human protein in nature. If they have an allergy, most likely it was due to a protamine-containing insulin. Okay. So again, in that protamine, you guys remember protamine? Where did we hear about that one before? Yeah, reverses heparin. This is the same exact product, just including the insulin in order to help to increase its duration of action. But so if they have an allergy to, say, protamine, like they got it after surgery, after receiving a bunch of heparin, they can't receive a protamine-containing insulin because they're going to have a reaction to that as well. Okay, and vice versa. Because again, it's kind of like when someone says, "I'm allergic to epinephrine." It's like you can't be allergic to epinephrine. Like you'd be dead, right? Same thing to the insulin. It's usually related to the dosage form and what other stuff is in it, right? So if someone has an epinephrine allergy, they probably have a sulfite allergy, right? Because it's used as a preservative in a lot of epinephrine-based products. Some people have a reaction to that. Here, they have a reaction to insulin, usually is due to the protamine that's contained in some of those formulations. So very rare occurrence you see with that. Some patients will develop antibodies against the insulin itself, so this is kind of an immune insulin resistance to where these IgG antibodies will start to bind up the insulin and keep it from having its mechanism and keep it from lowering blood glucose. So rarely you may see that where you're like, man, my patient's just requiring more and more and more insulin, even though they say they're sticking with their diet and they're doing all these things right, but they're just not getting their glucose under control. Could be related to that. Very difficult to tell. There's probably some lab tests specifically for the IgGs, but maybe asking an endocrinologist, you probably know a lot more about that. And then some patients will have injection site reactions. So a lot of the insulins, people will just keep them stored in the fridge consistently. Make sure they kind of roll it in their hands for a little bit to warm it up, because otherwise you can see some bit of vasodilations, and they may think they're having a reaction when really it's just the cold insulin causing the blood vessels to kind of open up, right? Okay, other things you can see are going to be some lipodystrophy at injection sites, so make sure they're kind of rotating around, not injecting the same site every single time, because that can lead to some lipodystrophy there. And then weight gain can be the other problem. So this is an important thing to note here, is that any drugs that are increasing insulin production, so we'll look at some of the type 2 drugs that can increase insulin production. Insulin as well, being given exogenously, will cause weight gain. Okay, so it can be problematic, especially if your patient already is overweight, or especially if they're very sensitive about their weight and gaining that can be problematic, especially like some of our adolescent patients. They can have issues with that and may not want to stick to their insulin regimen like they should because of that. So just be aware, be sensitive to that fact. Okay, so a couple of drugs which can interact with insulin, maybe to make decrease the hypoglycemic effect or make insulin work less effectively. Lots of drugs can do this. So some of the big ones that I'll point out here, anything that is proadrenergic, right? So because I mentioned that sympathetic nervous system, that increases glucagon secretion, increases gluconeogenesis. So things like epinephrine, things like dobutamine, all those things can increase glucose concentrations and make insulin work less effectively. But also things you may not think about, like oral contraceptives can have some negative effects on glucose. Corticosteroids, we already know about that because we already mentioned how corticosteroids cause hyperglycemia. That's a problem there. But even things like smoking, thyroid hormone, all these things can make insulin work a little less effectively. So be aware of those interactions and make sure you're kind of assessing all kind of components of the patient to make sure to find out why their insulin's not working for them. And then some things that can increase the hypoglycemic effects of insulin are going to be things that are blocking the sympathetic nervous system. So imagine if you have like alpha blockers or beta blockers, that can be problematic. Alcohol can also do this as well. I've seen a number of younger patients who go off to type 1 diabetics who go off to college and they want to go party for the first time and they don't realize the interaction between alcohol and their insulin, and they get hypoglycemic and they have to come into the ER. So that can be kind of a sticky situation there. The other thing with beta blockers specifically is what's the problem with beta blockers and diabetics? I think we've talked about it before. Yeah, they can't tell that they're hypoglycemic, right? So what does a patient look like when they're hypoglycemic? Shaky, sweaty, usually pretty hangry, right? They're pretty in a bad mood. So a lot of that can be blocked by beta blockers. So if you're blocking those skeletal muscle receptors, you don't have the shaking, you may not have the sweating. So you may have this kind of prolonged period where they don't realize they're hypoglycemic until they're kind of having more kind of severe symptoms. So just be aware that can be an issue for those patients. It could be an interaction. Okay. Let me finish up this section and I'll let you go for a break. So indications for insulin. So any type 1 diabetic patient is going to require insulin. So that's going to be automatic prescription for them. Pregnant women with type 2 diabetes, we mentioned this in the OB-GYN section, but because insulin is so close to what the mother's naturally producing anyway, this is probably the safest thing to give in regards to safety for the fetus. So this is going to be the preferred method if they can't control it with diet alone. And then type 2 diabetics who are not being controlled by diet or exercise or oral medications by themselves. We'll talk about when to initiate that a little bit later. We get into more detail on that, but just be aware that's usually kind of a last kind of stop for a lot of type 2 diabetics is moving over to using insulin. Diabetic ketoacidosis, we already mentioned kind of what the pathophysiology is for that, but that's going to be the reversal agent essentially to fixing DKAs by giving them insulin to allow their cells to start intaking that glucose and start processing it more effectively. Sometimes you will see type 2 patients who will develop this hyperglycemic hyperosmolar non-ketotic syndrome, it's HHNS. This is where they get, it's kind of like their version of DKA where they don't really get as acidotic, but their glucose levels get super, super high. They can be up in like, 500 to 1,000 kind of range. That can be one case where you use insulin or help to reverse that. And then hyperkalemia. Insulin also helps to drive certain electrolytes intracellularly, and so you can utilize insulin to drive potassium in the cells and use it for hyperkalemia. All right, everyone get their bullets of sugar to stay awake for the second half of this, right? Yeah. Good. Okay, perfect. All right, so looking at how we're going to be doing these insulin regimens for our type 1 diabetics specifically, you have to match things to their lifestyle, because the goal here is to try to provide them as normal a lifestyle as possible, just with the fact that they have diabetes. It shouldn't be totally ruining things for them otherwise. But biggest way that we're going to be measuring their glucose is going to be with usually finger stick. Actually, I have one student who has a subcutaneous kind of check. She actually wears on the back of her arm, and it connects via Bluetooth to her Apple Watch, so she can actually monitor her glucose at all times. So it's actually pretty cool. You have to calibrate it quite often in order to do that. Also, if you are considering looking at, say, subcutaneous glucose concentrations versus the bloodstream concentrations, it doesn't equilibrate as fast. So sometimes you have to worry about how fast that equilibration is happening, to where she might be hypoglycemic and it might not read it for a little bit subcutaneously until until it finally equilibrates. So kind of keep those things in mind. But there's all kinds of new ways that diabetes can be managed nowadays. They're also working on things like having a kind of a closed loop system, to where like a subcutaneous pump will be communicating with a constant glucose checker to basically gives you an artificial pancreas, right? So that's kind of the goal here, is to try to automate the process as best we can. So maybe one day we'll be to a perfect solution for doing that. So it's kind of a cool new thing that we can do for them. Anywho, but yeah, so traditionally a lot of finger sticks to check their blood glucose, and they're on this kind of basal bolus regimen. Okay, that basically means that they're going to get their basal dose, usually in the morning, sometimes at night, of a long-acting insulin formulation, and then they'll get their bolus doses around mealtime. Sometimes we'll get like an extra correction dose, say like before bedtime or something. But usually this requires multiple daily injections they're going to have to get. Some patients, though, I mentioned, if they're well controlled, if their diet's really dialed in, they can go ahead and transition over to that continuous subcutaneous insulin infusion. It can be very, very useful for some of them to kind of help not have to do all those injections all the time. The kind of the sword that you're balancing on between falling off one direction or the other is that the more frequent that you're going to give insulin, the tighter glycemic control that you're going to have, right? So you can keep their glucose in a normal range for a longer period of time, but it also means you're kind of increased complexity, meaning you're going to be giving your doses more frequently, and also you run the risk of, if I give more insulin, I'm going to have potential risk for hypoglycemia. Absolutely. So you run the risk of hypoglycemia with the more complicated your regimens get. If I give insulin less frequently, I'm going to have less chance of hypoglycemia, but I'm also going to have looser glycemic control. So you may have bigger fluctuations, especially on the hyperglycemic side, if not receiving it as frequently, right? So also you need to be looking at their physical activity and also their carbohydrate intake in order to make sure their insulin doses are matching appropriately, right? So can I just say put a type 1 diabetic on the same dose of short-acting insulin around every meal? No, I'm not going to have very tight control of that, right? In some cases, they may eat less carbohydrates and may cause their blood sugar to drop lower. Sometimes they might go for ice cream. They have a ton of carbohydrates coming in. Their blood glucose gets very high. So oftentimes we're trying to adjust the dose in order to help to counteract that. So, and again, the insulin injections that we're giving should be mimicking what the pancreas should be doing normally as best we can. So the timing of the insulin onset, the peak and the duration of the effect should be matching the meal patterns and also their exercise schedules, right? So this is why you just using, say, a once or twice daily dosing usually is not going to be good enough for these patients. You'll see with our type 2 diabetics, you can usually get away with, like, say, especially if you're just starting off with like a once daily long-acting insulin, that's usually okay for them. But for your type 1 diabetics, you need to be a little bit more frequent than that. So again, just looking at how we're trying to match up what the pancreas would be normally doing with a basal and a bolus secretion of insulin to match up with the glucose that they are seeing in the bloodstream. Okay, so we're trying to mimic this as best we can. So I'll show you a couple slides with different regimens and just a little bit to kind of talk about those. But generally, the insulin doses should change depending on both their carb intake and also their exercise. So you imagine if they're exercising, they more or less insulin. Probably less, right? Because they're using up that glucose in order to fuel the muscles and all the other things during exercise. So again, you don't want to give them the same dose because then they may get hypoglycemic potentially. So typically long-acting insulin doses, if you're using something like the NPHs, like those would typically be twice daily dosing of those, so it'd be like kind of in the morning and at night, versus something like your long-acting forms. You'll see those are going to be better just once daily, either in the morning or at night, but not both. Sometimes really resistant patients, you may need twice daily dosing of those really long-acting ones, though. So kind of the two main regimens that you'll see patients being put on are either going to be called a sliding scale or a carbohydrate counting or carb counting regimens. Okay. Basically, sliding scale, what that means is that the dose, you're going to give a different dose based on what the preprandial glucose reading is. Okay, so basically before they eat, they're going to check out blood glucose and see what it is, and then they're going to give them a dose based on whatever it is. So for instance, you'll see, especially on the hospital side, you'll see a lot of different sliding scales being used. But they say, if your glucose is between say 100 to 150, you're going to give this many. If it's between 150 and 200, you're going to give a little bit more. So you can kind of adjust your insulin dose based on the preprandial glucose concentrations. Basically, you're going to get to a point where you can kind of learn your patient a little bit. And again, to some degree, they're all kind of snowflakes. They're all going to be a little bit different. But basically, you learn how much 1 unit of insulin will correct their blood glucose, right? So initially, you may start out with just a standard, say, okay, here's your kind of cookie cutter sliding scale. We're going to use this for you until you can kind of figure out how they respond to insulin, how resistant they are or not resistant, and then adjust it to where you can kind of really dial it in to make sure that they are getting the kind of most bang for their buck out of their insulin. The other method to do this is going to be the carb counting, where basically they're going to be adjusting their insulin dose based on how many carbohydrates they're intaking, right? So basically you have to look at, this is going to be more difficult from kind of a knowledge standpoint, because you have to kind of learn, like, okay, how many carbs is in that hamburger I'm about to eat? Okay, would you guys be able to figure that out, right? Yeah. Okay.
There's apps.
There's apps, absolutely. So it's become easier, right? So things like MyFitnessPal or other things like that, make it much easier to be able to kind of figure out, like, what are the patients actually ingesting. So that's kind of a nice thing nowadays, where technology is helping us out quite a bit there. But basically, you can figure out how many carbohydrates that 1 unit of insulin will take care of based on their insulin sensitivity factor and things like that, and correct before the glucose comes in, right? So basically, one is being a little bit more reactionary, and one's being a little bit more proactive, okay? So I probably see, at least as far as our pediatric endocrinologists go, most of them are moving over to carbohydrate counting. And this is where it is super imperative that you have really good diabetes educators. Can't speak enough about how a good educator can really make the difference for some of your patients, right? They can decrease, rehospitalizations. They can really make sure they're really tuned in to their regimens and getting really good therapy out of that. So good educators cannot be discounted. So looking at a few different regimens, here's what you may see some patients being put on potentially. So if you were to look at, say, just a normal plasma glucose concentrations along, just a normal day, right? So here's, your basal amount of glucose being, seen in the bloodstream, and then you have your bolus is here around mealtime, okay? So if you had normal plasma insulin concentrations, if you had a fully functioning pancreas, this is what the insulin concentrations would kind of look like in order to respond to those spikes in glucose, and also to deal with that kind of basal amount of insulin being released there. Okay, so we're trying to mimic that with our insulin regimens as best we can. So here would be an example where we're going to use regular insulin, which regular is going to be used for kind of basal or the bolus, that regimen. Going to be used for the bolus, right? Because regular insulin is going to be short acting, right? So regular insulin is going to be more for around meal times, whereas we can use this NPH insulin as a long acting form in order to provide kind of longer kind of basal coverage for us. So for instance, if you can look here, you would have a patient getting both their NPH and their regular insulin around breakfast time, right before breakfast. You see how the regular is going to spike before the NPH as far as the activity goes. So that's going to kind of deal with that increase in glucose that you normally see for those patients. Whereas the NPH is going to have a kind of a longer time to get to that peak, but it's going to be lasting around the 12 hours or so, right? So this would be a case where you again would kind of redose around dinner time, where they get another dose of regular and then another dose of NPH. So how many injections are they doing a day with this one? So this one, because you can mix NPH along with regular insulin, this is where you get some of those mixtures like 70-30s and things like that. You could actually get away with 2 injections a day with this one, okay? But we mentioned fewer injections means you're going to have looser control on their blood glucose. So you're going to have higher peaks and troughs essentially based on that. So on the other hand, if we were to use something like a regular insulin plus an ultra lente, or say for instance if we were to use one of those ultra long actings like Levemir, Lantus, something like that, you can see where you just would give, this would actually end up being kind of 2 different injections in this case, but you'd give the regular around meal times, and then you just have the long acting formulation given just once a day, and kind of provides that nice kind of basal coverage, right? You can kind of adjust that based on what their kind of fasting blood glucose concentrations are to see where they need to be at. Okay, and of course the ultimate way to do this would be to have the subcutaneous insulin pump, where you can see how it would actually provide very similar coverage. It would look almost identical to what the body would normally be secreting based on both the boluses that they're putting in and also the basal concentration that they're just kind of constantly infusing. Okay, that makes sense? So more injections, more complicated but tighter control, but more risk of hypoglycemia. Okay, so I'm not going to make you guys memorize these numbers. I just kind of want to give you an idea of kind of how we come up with these regimens and how patients are getting started on this stuff. So if you're looking at the initial insulin dose you would give a patient, say for instance, type 1 diabetic, you may start at say 0.5 to 0.6 units per kilo per day. Okay, it's kind of a good, that would be mimicking what their pancreas would normally be spitting out. That'd be a total daily dose there. On the other hand, you may see like a type 2 diabetic, say anywhere between 0.7 to 2.5 units per kilo per day. Why do you think the type 2 diabetic needs more? They're way more insulin resistant, right? So it takes more insulin in order to cause the same exact effects as you see the type 1 diabetic, who has ostensibly no insulin resistance because they can't send out any insulin of their own, right? So typically the way you're going to break up the dosing is that you would do a 50-50 split between your long-acting form and then your short-acting or your mealtime insulins. Okay, so for instance, I'll show you a regimen here where, let's say for instance we had a 40-kilogram female who just got diagnosed with type 1 diabetes. We would basically do 0.5 units per kilo per day times 40 kilograms, and so you say, okay, she needs 20 units in a day of insulin. Okay, so we then break that up in 50-50. Half of that would be her long-acting form. So for instance, we do say 50% of that 20 should be, this is actually a BID regimen. So if you do 50% of that would be 10 units. So you get 10 units a day of her long-acting. So you could do 5 units of insulin detamir subcutaneously twice a day. Okay. You could conversely just do 10 units in the morning, for instance, and that would be an okay regimen as well. The other 50% is going to get divided up amongst the mealtime hours. So for instance, at breakfast usually you're going to have a few more carbohydrates during that meal, so you're going to have 20% of it they put there. So in this case it would be about 4 units of insulin. Lispro, we mentioned that's a short-acting insulin with breakfast, say 15% at lunch and then 15% at dinner time. Okay. Now, for instance, if they think, okay, well, I'm going to have like a really big carbohydrate filled dinner, then maybe they can just kind of readjust that essentially. Okay. So keep in mind, this is just going to be a kind of a starter for them, and then once you kind of figure out what effect 1 unit of insulin will have on their glucose, you can kind of adjust it and really tune it in to make sure they have really good tight control for those patients, right? But obviously with this kind of regimen, differences in meals can have big effects on their glucose because you're really only giving a single dose for this. But that's why you start with this and then you kind of tailor it custom to your patient individually, right? Does that make sense so far? So again, 50-50 split from the long-acting and your meal times, and then you can kind of break it up from there. Okay, so we mentioned insulin pumps. They can provide both the basal and the bolus regimens throughout the day, but they do require the patient to input things like their mealtime carbohydrates to calculate their bolus dose. That's kind of the most common thing that I see. But you need to make sure they can retain kind of extreme detail or attention to the details here, because if they goof it up, they can cause significant hypoglycemia. If they're not tuning in right, they can have very high glucose concentrations. Sometimes you will see malfunctions in the pump. So I will have some kids who come in and get admitted to the hospital because their pump either stopped working, so they got really hyperglycemic, or it was working a little too well, hypoglycemic. It's probably more common to see the hyperglycemia. But just keep that in mind. Yeah, it does require a lot of training for these patients, but once they get it going, like it's usually kind of a very nice thing for their lifestyle, just because it's kind of always there, just infusing, and you don't really have to think about it quite as much as you would have to do, these injections kind of throughout the day. Okay, so how do we treat hypoglycemia? So how do you kind of define hypoglycemia? Yeah, depending where you go to, maybe it's less than 65, maybe less than 70. It kind of depends on your institution, what they kind of define as their reference range. Keep in mind, especially patients who have really kind of frequent episodes of hypoglycemia, if they have some autonomic neuropathy, especially what you might see with like your uncontrolled type 1s or some of your type 2s, they can have this hypoglycemic unawareness. This is very similar to what you would see with like the beta blockers being on board, kind of blunting those responses to hypoglycemia. So they may not actually be aware of the fact that they're getting hypoglycemia, but usually there are certain signs and symptoms they just know, hey, I'm getting low here, right? So in order to treat that, what are we going to give them? Give them sugar, right? So obviously that's the problem, so we're going to correct it with more sugar. So typically, and I don't know if you guys have ever been hypoglycemic, but I've been a couple of times, and boy, I just want to like, eat everything in sight, right? I'm just like, oh my gosh, let me just. So you usually end up overcorrecting, right? So in a lot of cases, they try to have patients kind of adhere to this rule of 15. Where they would say, okay, if you're hypoglycemic, go ahead and do 15 grams of simple carbohydrates, right? These are things that get broken down very quick in the GI tract, can be absorbed very quickly, and can be utilized directly for energy. So this kind of equates to 8 ounces of orange juice or 8 ounces of milk, or they have like glucose tablets that patients can take, sometimes gels they can use, kind of this Go-Gurt packs or something that are just full of like carbohydrate gels. And then check your glucose again in 15 minutes, and if it's still below 70, then you go ahead and repeat the same process, okay? That is requiring, though, that your patient is awake and is able to tolerate things orally, right? So what do you do in cases where they cannot do that? Yep, so then we have other regimens for that. So we have things like glucagon that we can utilize for these patients. So we already mentioned glucagon being an exogenous hormone that your body is secreting from its alpha cells. We can give it exogenously as well to help stimulate glycogenolysis and gluconeogenesis from the liver, right? The liver is going to start producing glucose for us and hopefully correct their blood sugar. This is good if patient is unconscious, especially in their out of hospital setting. So a lot of patients, especially when they get a new diagnosis, they come back, to the pharmacy with like, 10 different scripts, right, for different supplies and things like that. But very frequently, we'll send them home with a glucagon kit, and it looks just like this. Glucagon itself being a hormone, it's a protein. They dry freeze it, or freeze dry it. I'm sorry. So it's a powder essentially. So they have the kit here. We can see the syringe has the diluent. You would inject into the vial, kind of swirl it around. You don't want to shake it because anytime you shake proteins, they can bubble up and not be effective anymore. Reconstitute it, draw it up, and then inject it into the patient intramuscularly. Okay, so kind of similar to sending a patient with severe peanut allergy home with an EpiPen. This is kind of the same thing we're doing with these type 1 diabetics, right? So the other thing to consider, though, is that how long have they been hypoglycemic for? So again, when you are hypoglycemic, your body is starting to kind of activate a lot of those kind of counter-regulatory mechanisms where you're increasing your sympathetic nervous system. You're trying to activate glycogenolysis and gluconeogenesis anyway. If they've been hypoglycemic for a while, they might not have a lot of glycogen stores, right? You especially see this in very young kids who don't have a ton of glycogen built up, where you can give them glucagon, might not be super effective. Okay, so if glucagon is not working, what can I do then? Give them IV dextrose, right? So that's what we're going to do at that point. So the other thing to look at for glucagon, lots of nausea and vomiting associated with it. So you may want to, if you're prescribing a glucagon kit, maybe give them like some Zofran ODTs or something like that, the oral disintegrating tablets, because they're probably going to throw up from this, right? Sometimes you will see glucagon being used for, because of the fact it causes nausea and vomiting is related a lot to it releasing some of the pressure on the lower esophageal sphincter. Sometimes we'll actually do that if we have a foreign body ingestion. So if you had a kid that came in and swallowed something and you can do a chest x-ray and you see it there in the esophagus, sometimes the GI docs will recommend giving a dose of glucagon to try to help it pass. Doesn't work all the time, but occasionally it can be useful for that. But so be aware of that. Then IV dextrose is going to be the next thing that we're going to give and help correct their blood glucose. So glucagon's nice because you can give it intramuscularly. You don't need IV access for this. So you may see this being used a lot like in the pre-hospital setting as well. But once they're in the hospital, then we can also use IV glucose. So there are different concentrations that are available. So there's D10, which is, what do you think D10 means? Dextrose 10. It's 10% dextrose, right? So that means for every 100 mLs of water, right, because it's usually dextrose in water, there is 10 grams of dextrose, okay? A good rule of thumb, I don't know if I told you guys this one or not, but if you have a percentage of a drug, you want to figure out how many milligrams per ml it is, move it decimal place over one spot to the right, okay? So D10 would be 100 milligrams per ml of dextrose, right? D50, 500 milligrams per ml of dextrose. That's good because you can use that to help calculate doses and how much volume of fluid you want to give for these patients. But basically, there's a couple different concentrations. Usually, in your hospital crash carts, you're going to have D50 available for adult patients, and usually D25 more for your infants. And then D10 is also available as well. Obviously, the less concentrated it is, the more volume you're going to have to give. So in some patients where you don't want to give a ton of volume, this may lead you to use more concentrated varieties, right? Usually, the dose is going to be anywhere between like a half to 1 gram per kilogram, and so usually caps out a max dose around 25 grams. So if you would imagine, D50 comes as a kind of a pre-filled syringe of 50 mLs. So if I had D50 and I know 500, it's 500 milligrams per ml times 50 mLs, it's going to be how much? 25,000 milligrams or 25 grams. So that's why they say, give me an amp of dextrose, or give me an amp of D50, and that's what they're referring to, is 25 grams basically of dextrose. I don't like the term amp of anything because that doesn't really mean anything specifically, but if you want to say, give me 25 grams of dextrose, I will hand you that full syringe, you can inject that, right? So just be aware of some of the nomenclature there. Be aware of using higher concentrations. You're going to cause more kind of damage to the blood vessels potentially, right? So it's high tonicity. It will cause some thrombophlebitis. If you extravasate, you can see some tissue damage being done there, especially the higher concentration. So for instance, I had a patient who is comatose and is on the verge of seizing. It's an adult patient. I'll give him D50 in the vein, no problem, right? A little thrombophlebitis in order to save life, that's okay. Small children, D25 is probably okay as well. If you can, try to use a less concentrated form. If they're, maybe having some altered mental status, but they're still kind of still with you to some degree, using less concentrated forms is better for the veins. So for instance, if I had a kid who came in who's hypoglycemic, I'd probably use D10 bolus, and then you can put them on some maintenance fluids, have some dextrose in it later on, right? So just be aware that if they're not communicating with you, if they're unconscious, glucagon is a good option. Also, IV dextrose is your next best bet, okay? But glucagon may not be always effective if they don't have good glycogen stores. IV dextrose is always going to work. Okay. All right. So what are our treatment goals? Probably depends on who you're looking at. But this is going to be more for type 2 diabetics, but this could also apply to some of your type 1s. What are we shooting for? So we want an A1C, usually less than 7%. If you're going by the American Diabetic Association, I meant to put down here 6.5 for the American College of Endocrinology, but less than 6.5%, so they have a little bit tighter reins on that. And then you can look at like your preprandial glucose, ranges anywhere between 80 to 130, and then postprandial less than 180. So it's really your goals for your diabetic patients to get their glucose under control. And so we'll look at, now we're going to be kind of switching gears and moving more to our type 2 diabetics and how we're going to help manage that with oral meds. So typically with type 2 diabetes, once we have diagnosis, we will start with lifestyle changes. So get your diet in check, start exercising more, all that good stuff. And when that fails, then they move on to monotherapy with oral medications. Okay, we will typically try one oral medication at first, and then you kind of add on other things to see kind of what effects are going to have. We'll talk about where it makes sense to kind of combine different mechanisms in order to get better effects here. We'll also talk about what the first go-to drug is always going to be for these patients. And then eventually, if they keep failing, not really getting good control, then we will move down to using oral medications along with insulin. Okay, it's kind of the general flow of things. Nowadays, we actually have some other subcutaneous injections we'll talk about that we'll use kind of before insulin, but we'll talk about where that fits in. So just to look at kind of the difference between someone who has, say, normal glucose tolerance, which would be in this kind of blue line here, versus someone with impaired glucose tolerance versus someone with type 2 diabetes. If you're looking at the actual amounts of insulin that they're secreting between the bunch, you can kind of see some interesting things here. So for instance, obviously the patient with type 2 diabetes and impaired glucose tolerance is not going to have as good of an ability to really help kind of regulate their glucose, right? right, in the bloodstream. But if you look at the insulin concentrations that they're secreting, you can see that for your patients with normal glucose tolerance, they have a spike of insulin and then it kind of goes back down over time, right, which makes sense. But for your patients with either type 2 diabetes, or actually this one with impaired glucose tolerance, you notice here they're releasing a whole lot more insulin, kind of for a more kind of sustained period of time in order to help try to manage that bolus of glucose. On the other hand, though, why do you think the insulin secretion from the type 2 diabetic is lower than the one with impaired glucose tolerance? What do you think that is? Not necessarily. I mean, that is happening where you have more glucose around, like they're trying to secrete more insulin in order to help deal with that. Usually they don't have enough insulin that they're secreting to manage. Usually the glucose is going to be a bigger effector than you would see the actual insulin, causing that negative feedback loop. So that wouldn't be it. So imagine, again, remember I said that these type 2 diabetics are having kind of constant destruction of pancreatic tissue over time. They're wearing out their cells, okay? So someone with impaired glucose tolerance is able to kind of have a higher insulin concentration because they are still able to produce enough insulin to try to deal with that increased blood glucose. Your type 2 diabetics, so as they get more progressive, you're going to see they can release less and less insulin, okay? Their cells are just not really able to keep up with the demand anymore. They're getting tired out. They said, no, I'm going in early retirement. No more insulin for me. Okay, so this is where we're going to look at some of the mechanisms here where they say, okay, well, certain drugs will increase insulin release. Other ones are going to make the insulin that you're already releasing work better. So we'll see how those kind of interplay with one another. Also, if you're looking at glucagon, normally glucagon gets suppressed in the presence of insulin, especially in the presence of carbohydrate intake and things like that, because glucagon is really trying to raise blood glucose. But if you're ingesting a bunch of carbohydrates, you don't need a ton of glucagon. So this is one of the other big things that you're going to see with these type 2 diabetic patients, is that normally when you have normal glucose tolerance, you're looking at insulin secretion in response to, say, a mealtime thing. You see a big bolus here and then go down. Again, we already saw this in the last slide with the insulin release in the type 2 diabetics. But similarly, you're going to see that glucagon gets suppressed in the normal glucose tolerance patients in the presence of food, whereas those patients with type 2 diabetes do not get that same suppression. So not only are they releasing less insulin to deal with that high blood glucose concentrations, they have more glucagon floating around, which does what to the glucose? Increases it, right? Glucagon causes the liver to produce new glucose, so kind of two problems here we're dealing with is that they do not have enough insulin to deal with the glucose, and they have too much glucagon around. So we're going to look at some drugs that affect that as well. So the major classes that we're going to be talking about, we're going to have drugs that stimulate the pancreas to make more insulin. So this will include our sulfonylureas and our meglitinides. We will have drugs that sensitize the body to insulin. So these are going to be our thiazolidinediones. You can call them TZDs for short. We also have our biguanides. You're going to have things that slow the absorption of starches and carbohydrates. So that's going to be our alpha-glucosidase inhibitors. And then we're going to look at some of our newer classes of drugs, things that help to make the incretins, things like amylin, work better. These are going to be called glucagon-like peptides, and we'll look at those in a minute. And then also the newest class that we have are going to be these SLGT2 inhibitors, which actually work to decrease reabsorption of glucose from the kidneys. Okay, basically just peeing out all the glucose instead of reabsorbing it. So we're going to go into detail on all of these. Just to kind of give you an idea of the comparison of changes in fasting plasma glucose and also A1C reduction that you can see with these, all of them can be effective. And this is where you can see multiple drugs being used at the same time in order to help kind of get some synergy here to have positive effects on reducing A1C and the fasting glucose. Obviously, they're not all created equal. You're going to see that some are going to have a lot more bang for their buck, especially things like looking at a sulfonylurea versus something like a meglitinide. That looks very similar, but you're going to see that they're not really going to be one-to-one in use in the clinical world. So we'll kind of look at some comparisons there and see which ones you're really going to be most likely to use in practice. But we're going to talk about all of them anyway, even though you might not use many of them because you need to be able to recognize them if a patient comes in at one, right? Okay, so first thing we'll talk about is our sulfonylureas. These are going to be things that help the pancreas to send out more insulin. Okay, there's a couple of generations. The one in the first generation to look at is chlorpropamide. That's probably the only one you're ever going to see, so I'd probably just remember that one from the first generations. And then your second generation ones are much more prevalent. So where you see your glimepiride, glipizide, and glyburide all being used pretty frequently in type 2 diabetics. So definitely know those ones. And so these get used very very frequently for their effects at increasing insulin secretion. They do this by blocking off those potassium channels. We talked about this this process here where glucose comes into the beta cell and will get converted to ATP. ATP closes those potassium channels, which eventually causes downstream release of insulin. So the swine ureas just come in themselves and say, well, we don't need the ATP. We're just going to close off this potassium channel. And it's going to cause the depolarization, increase calcium influx into the cell, and then release more insulin. Okay. So this can also lead to some effects downstream by increasing more insulin. You can also see less glucose production in the liver because you are kind of having that suppression effect on glucagon. So that's going to be beneficial there. And you can also see some good effects on insulin receptor sensitivity and also the numbers of receptors. So we'll have some kind of pleiotropic effects making insulin work a little bit better, but the primary mechanism here is that it's making the beta cells release more insulin. So if you had to imagine, if you try to give this to a type 1 diabetic, what would happen to their glucose? Nothing, right? Because again, if they're not releasing any insulin on their own anyway, this is not going to help that at all, right? So keep that in mind. Because you're going to see that some drugs, especially for patients who are like a type 1 diabetic who really wasn't well controlled, they may actually get some benefit from some of these medications, but sulfonylureas are not going to be one of them. Okay, we'll talk about some in a little bit that could be potentially useful. But you're going to see that they're mostly going to be metabolized in the liver. May have some active metabolites, which kind of extends the duration of effect for some of these. And they're also going to be highly protein bound. So you do worry about things like protein binding interactions where one drug can kick another one off and see some increased effect there. So be aware of that. This is also not one we want to use for our pregnant patients, even though the idea would be to increase maternal secretion of insulin from the mom. That would help the fetus. You don't want to do that because that can actually deplete insulin from the fetal pancreas and essentially initiate kind of type 1 diabetes for them, right? So you don't want to do that. Chlorpropamide probably should not be used in elderly patients, especially because it's very, very long acting. So the risk for them getting hypoglycemic kind of in a delayed fashion is going to be increased for them. And also you can see this disulfiram-like reaction with alcohol. Do you guys remember what other drug causes this?
Metronidazole.
Yeah, metronidazole or flagyl can do that as well. What is that reaction? Nausea, vomiting, they're really flushed. Do you guys know the mechanism for that? So remember, alcohol gets broken down by two enzymes. One's alcohol dehydrogenase, which turns into acetaldehyde, and then it gets broken down by acetaldehyde dehydrogenase into more water-soluble molecules that can be peed out, right? If you inhibit the acetaldehyde dehydrogenase and you have buildup of acetaldehyde, that causes the nausea, vomiting, the flushing. That's basically what's happening here with disulfiram, what happens with chlorpropamide, and also metronidazole potentially. But again, longer acting agents, the longer they stick around, the more likely they are to cause hypoglycemia. So you're probably going to see the biggest risk for this with both chlorpropamide and glyburide for these patients. I probably see glipizide probably being used most frequently by most patients. We'll talk about why that is in just a minute. Again, we have glimepiride or Amaryl here. Again, all of these they're very effective at rapidly correcting the glucose, but again, your risk for hypoglycemia is just larger just due to the fact that the beta cells are just kind of spitting out insulin irregardless of carbohydrate intake into the body. You may see some of these used in combination with insulin. It can actually be kind of insulin sparing and actually reduce the amount of insulin the patient has to inject based on the fact that you're causing beta cells to kind of work in overtime a little bit. Glyburide and glipizide are going to be also available here. Notice that the glipizide will come as an XL formulation that we see very, very frequently being used. And so the way that XL formulation works is kind of unique. It comes as a little tablet, and if you look at the tablet, you can actually see a tiny, tiny hole drilled into one side of it. And so basically the drug is all contained in there, and based on osmotic pressures in the GI tract, it'll actually force the drug out very slowly through that tiny hole all the way throughout the GI tract, right? So if the patient sees a pill in their feces, that's okay. It's supposed to be there, right? Because the pill itself does not actually get absorbed. It's just the drug has already been excreted out of that tiny hole, okay? So, weird things people find in their poop, you should probably let them know about it beforehand. Usually, if you ingest these before mealtime, usually 30 minutes or so, it kind of helps them work a little bit more effectively, just because that's kind of the time where your pancreas would be normally secreting insulin anyway. That'll be more important when we talk about our meglitinides in just a minute. So hypoglycemia obviously is the biggest risk with this group of drugs, but also weight gain is going to be important here. Similar to what we saw with exogenous insulin, anytime you're increasing insulin release, you're going to see weight gain associated with this. This is a big side effect from these. And again, for a lot of your type 2 diabetic patients, they may be overweight to begin with, so it could be kind of a negative effect for them. Other than that, pretty well tolerated for the most part. You may see resistance develop over time. Why do you think that is? Not downregulation necessarily. Yeah, so as the diabetic patient gets more and more progressed, they are going to have further destruction of those beta cells, right? So at some point, they're just going to be completely worn out, and that's usually when your patients need to transition over to exogenous insulin as well, right? They get to that point where these drugs really aren't working for them very much anymore. That's when you can transition over to sub-Q insulin. Okay, obviously you do not want to use this in order to correct DKA, so that would be one contraindication for that one. Type 1 diabetes, we already talked about why that would be the case, and then do not want to use this in pregnancy or breastfeeding patients. Okay, mentioned the protein binding interaction you can see there. Anything that can cause hyperglycemia will obviously kind of counteract the effects of these sulfonylureas. That can be one interaction you would look out for, and then disulfiram reactions with chlorpropamide. The next group of drugs is called the meglitinides. These are very similar to your sulfonylureas. There's two here, repaglinide and ateglinide. They don't get used all that too frequently. The reason for that is that even though they work very similar to the sulfonylureas, they're still blocking those potassium channels. It's only going to do it in the presence of high glucose concentrations, or basically high influx of new glucose. Okay, this means that these drugs really only work around mealtime. If I were to give these drugs, say, in the middle of the night when the patient is not eating anything, you're really not going to see a big increase in insulin secretion. You will with the sulfonylureas. Those work independently of mealtime or carbohydrate intake or anything like that. But the meglitinides have to be around mealtime in order for them to work effectively, which is why you probably don't see them being used that often. It's just easier for the sulfonylurea, just use it whenever. One important point here, though, is that if they miss a meal, probably want to go ahead and skip a dose, right? You won't be getting a whole lot of effect out of it anyway. You will see some of these drugs are being combined with metformin. This is probably the most common one to mix it with. Again, metformin is probably going to be the drug you start all your type 2 diabetic patients out on first. We'll talk more about that in detail when we get to the biguanides in just a minute. Again, very similar adverse effects they see with the sulfonylureas because, again, they're working exactly the same as those drugs did. Okay, this is a big group of drugs, or actually this is just really one drug we're going to be using from this group, but this is very important for use in type 2 diabetics. These are biguanides, and metformin is going to be the big one you see being used here. So glucophage, glucophage XL, glucophage, some people may call it, but this is going to be the most common one you're going to be see being used here. There was fenformin that got taken off the market because of fatal lactic acidosis. It's important to remember because you can actually see this with metformin as well. There may be a European form, see buformin potentially, but this is the most common one you're going to start all of your type 2 diabetic patients out on unless they have a contraindication. So what does this drug do? Well, basically it's an insulin sensitizer. Okay, so it does nothing to increase insulin secretion from the pancreas, but it can decrease hepatic glucose production. It's going to help to increase peripheral glucose uptake. So it's going to help to increase that sensitivity. So whatever insulin you are making, it's going to help it to work better, right? It's going to help to drive things like amino acids and carbohydrates into the cells more effectively. You can also see some decrease in carbohydrate intake from the GI tract. And so all those different mechanisms are helping to sensitize the body to make insulin work better. Okay. Note it doesn't really cause hypoglycemia because it's not really having any big effect on insulin directly. So it's kind of the nice thing is because you don't really run the risk of hypoglycemia, and it's so effective for helping kind of reestablish normal effects of insulin in the body. So this is why this drug always gets usually started for most of your type 2 diabetic patients. Also pretty cheap for the most part. So the drug is not metabolized in the liver, but this is important that you do not want to give it for patients who have hepatic dysfunction because lactic acid is a byproduct of some of the effects that metformin has on the body. So you're going to see increased lactic acid production, which needs to be cleared by the liver. If the liver can't clear it, then you're going to have problems. Also, the drug itself gets excreted unchanged in the kidneys, and so if you have bad renal function, you're also going to build up metformin. You're also going to build up lactic acid, so you don't want to use it for patients with poor renal function either. Okay. But you can have, this drug actually has probably either no effect on weight or actually has some mild effect to decrease weight, which is why this is another beneficial thing to start for lighter type 2 diabetics. But it's very useful for those to increase insulin sensitivity and to I see some positive effects on hyperlipidemia as well. Okay, so it's a really good drug to start off with for these patients. But adverse effects wise, you want to watch out for the GI upset. You can have diarrhea, nausea, vomiting associated with it. Sometimes by using the extended release formulation, that can help to mitigate some of those GI effects. So that's why you see a lot of patients being put on that, and that way it's only once a day as well. It can be useful. And then patients who have poor kidney function, you do not want to use metformin in. So there used to be a creatinine actual serum creatinine cutoff that we would use, but nowadays we're just saying, if you have a serum creatinine less than 30, do not use this drug in these patients. Okay, because basically, if there's a certain creatinine clearance cutoff, then we're not going to use metformin in under. So usually around 30, I think is probably where most places are going to fall. So less than 30, do not want to use metformin because you can run the risk of having lactic acidosis develop, which can be fatal in some cases. Okay, this is also really important when you're going to send patients for contrast. Say so a patient comes in, they need to get a CT scan for either PE or stroke or something like that. You want to make sure that you look to see if they're on metformin or not, because you can have contrast-induced nephropathy. We'll talk more about that in the nephrology section, but that can lead to buildup of metformin, buildup of lactic acid. That's been a big problem for some patients previously. Okay. So I mentioned GFR less than 30, don't want to use this. We used to do it. So if you ever see, something like serum creatinine of 1.4 for females or 1.5 for guys, don't use it. That's kind of gone by the wayside. Now we're just using this GFR of 30 for everyone. Don't use it in patients less than that. Other than that, you want to make sure that you're stopping it before surgery, because again, with surgery, you can see acute hits in renal dysfunction or renal function. So you can hold it for a little bit. They can deal with hyperglycemia for a little bit, or you can put them on sliding scale insulin while they're in house. But do want to hold it for at least that period of time. Also, surgery itself just increases lactic acid production anyway, so I don't want that to be kind of interplaying there. Okay, again, we're going to talk about the place in therapy for all these drugs just a little bit later. But the next group we'll talk about are going to be thiazolidinediones, or the TZDs, as they'll be called. The two big ones you're going to see being used here are pioglitazone and rosiglitazone. There used to be troglitazone, but that got taken off the market for liver toxicity. Okay, these are going to be working basically as an agonist for the peroxisome proliferator activated receptor gamma. You just call it PPAR gamma. That's fine for my purposes. Basically, though, what this is doing is it helps to regulate gene transcription for these insulin responsive genes. Okay, so these are also going to be insulin sensitizers. So it would not be uncommon to have something like, say like a pioglitazone plus a sulfonylurea, or say one of these, rosiglitazone plus metformin, right? So you can have the combinations because they're all going to be kind of synergistic with one another, right? Now, you wouldn't want to have a sulfonylurea with a meglitide because they're doing the same thing. Okay, so think about the mechanisms and how these can make sense to either use them or not use them together. So with these drugs, the TZDs, you're going to typically see increased peripheral glucose uptake and utilization, so that's good. It's helping to make the insulin that we're already releasing work a little bit better. You also see some decrease in the hepatic glucose production. I apologize for that. I'll correct that for the video, but decreased hepatic glucose production for that one, right? Again, these are all metabolized by the liver, so you do want to be careful with hepatic dysfunction, since there was that troglitazone that had some issues with that. And these do take some time to work, so maybe around 6 or 12 weeks to really get to the kind of maximal effect for these drugs. One of the things to worry about is the contraindications for who not to use the TZDs in. One of the things you worry about is patients with heart failure. Some of these can cause expanded blood volume and edema, so that can actually worsen heart failure for some of those patients. So especially if they're not really well controlled, might be one you want to avoid for those patients. Other things, again, look for changes in hepatic function tests. So if you start to see the ALT, AST start to rise, especially about 3 times the normal limit, then you probably would want to go ahead and discontinue this drug as well. So just be careful with that. You may see a little bit of weight gain with these, but usually not a ton, especially in comparison to your sulfonylureas. But otherwise, pretty well tolerated for the most part. So you will see some negative press about rosiglitazone if you ever go search about these drugs. basically when they did a lot of studies to look at the effects of some of these drugs on things like cardiovascular death and whatnot, they actually found that if you pulled all the data together, it looked like rosiglitazone had some increased risk for cardiovascular death. Okay, so it wasn't taken off the market because there really wasn't a strong enough association to do that. But for the most part, pioglitazone is probably going to be safer to use. Really hasn't been any data to show there's problems with that one. So just be aware if you ever see that. That's where a lot of this is coming from. Again, you can look at your p-values and tell which ones are significant, right? Hopefully. You guys know what odds ratios are still? Unless you blocked all of that out. See a lot of confused faces. You took that class at one point, I guarantee you. I was there for all of it. Okay. So another group of drugs we have here are going to be our alpha glucosidase inhibitors. You have two here. This is acarbose and miglitol. These basically are going to be working by blocking this alpha amylase enzyme and alpha glucosidase enzyme within the GI tract. So basically you're blocking intestinal absorption of carbohydrates. Okay. What do you think happens with carbohydrates when they're stuck out in the GI tract? The bugs eat them, right? So your bacteria start to metabolize them. What do they make? They make lots of gas, right? So lots of methane. There's been some explosions associated with these drugs, so just be careful. No open flames around these patients. Just kidding. Right. So the glucose does not get metabolized, so the colonic bacteria start to metabolize it, and so this is where you're going to see a lot of flatulence, a lot of abdominal cramping, and things like that associated with these drugs. So not really preferable by a lot of patients. They're not really absorbed very well, so that can be one beneficial thing. You may see maybe a pregnant patient being put on something like acarbose because it's not being absorbed. So similar to how you see drugs that don't get absorbed for hyperlipidemia are better for things like pregnant patients. But again, not a group of drugs I see used too frequently, just due to the adverse effect profile of it. So again, flatulence up to 77% of patients, as you might imagine, can be pretty problematic for a lot of people. Right? Okay, I'm going to go ahead and cut it there. Do you guys have any questions? If not, I will see you guys Thursday.